All right, OB and gynecology. This is a very interesting one because the whole process of forming babies is pretty complex. And like I was saying the other day, we are really not designed to do it very effectively. It would be way more effective if we had bigger, wider hips and we could just squirt out babies like pretty much every other animal in the animal kingdom can do. If you guys have ever watched other animals give birth, you'll know that, like I'm saying, they don't really scream or cry out or do any of those things that we would think of when we're watching a birth happen in real life, or a human birth, I should say. They just kind of stand there motionless while the baby squirts on out of them. Now, obviously, animals feel pain in different ways than we do, and they express pain in different ways than we do, but still, it works a lot better for all these animals. Probably that change happened when we started becoming bipedal, because when we became bipedal, those big pelvises weren't as stable. So the pelvis had to get a little more narrow and a little more stable in order to support the weight of the spine and everything above it. And that's probably when that change happened. Like I say, biologically, we are not very well designed creatures, but it's worked out for us through sheer determination. Now let's talk about a couple records relating to obstetrics and gynecology. I think these are kind of interesting facts about babies. For one, I want you guys to guess, what's the number of children, the most children ever birthed by a woman that we have a record of? How many kids do you think she had? 18? Come on, Molly. There's a TV show with someone like 19 and counting, so it's got to be higher than that. It's definitely higher than 18. Come on, think about Mormons. How many? 42. That's a great guess, Phil. It's too low. Too low. 50. Nathan, great guess. Great guess. You're still too low. Come on, these are rookie numbers. Rookie numbers. It's higher than 50. Keep guessing, guys. 89. Come on. No, come on, Phil. It's lower than 89. All right. We're not quite to that level yet. She's not an ant. 72. Now it's a little closer. It's 70, 60. The answer is 69. 69 babies. That's the record. This was a woman, lived in the 1700s in Russia. And by the way, the reason she had so many kids, they weren't all single births, I'm sure, as you guys guessed. You guys might know that twins run genetically in the families. They run in my family. I'm kind of scared to have kids. She had 16 sets of twins, 7 sets of triplets, 4 quads, and everything else was a single birth. Now, what's really amazing about this is she died, her husband remarried, and then he had 18 more kids with his second wife. So he had 87 kids. And as far as we know, that's the record for a male too. But that's a little harder to track. Now, what's also interesting about this is a woman in Russia in the 1700s, and we don't know her name, but you guys know what the Russians call her? They call her great, 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 great grandma. No, they don't know her name. They only know her by her husband's name because he was a real horn dog. And let me tell you, he needs 18 more kids. Come on. That's ridiculous. Now, this was in the 1700s, so I recognize you guys may not recognize that as a legitimate record. I get it. I see where you're coming from. There's a much more documented case that happened in the early 1900s called the Grenada Case. And what's interesting is this was a woman in Tuscany, which is in Italy, and her name was actually Gravata. That was her first name. And why is that funny? Think about what we say, para and gravida means para is being pregnant, and then gravida is live birth of a baby. I'm pretty sure I have that correct. Yeah, gravida is birth, and then para is pregnancy. So her name was Gravata, which is very suspiciously close to gravida. She had 62 kids in the early 1900s over a period of about 30 years. Now, again, a lot of them were twins, triplets, quadruplets. But what's really interesting about her is she had 36 girls in a row, which were all single or double or twin births. 36 girls in a row. That's like flipping a coin 36 times and getting heads. I think that was from a movie called Rosencrantz and Guildenstern, where he keeps flipping the coin. Or no, it was Rosencrantz and Guildenstern are dead, I think. He keeps flipping the coin, he gets heads over and over, like 74 or 5 times in a row. And they start having this whole talk about likelihood and probability. Anyways, that's just letting you know just kind of what the outer limits of how many babies a woman has had. Now, obviously, the record for the least amount of babies ever birthed would be 0. But let's talk about another record, one that's not quite as fun. The youngest woman ever to give birth. Let me rephrase that. The youngest girl to ever give birth. How old was she? Youngest ever birth. 9. That would be really young, but she was younger than 9. Molly, she was younger than 7. Yeah, younger than 7. Not even kidding. She was younger than 6. She was 5 years, 7 months, 21 days when she gave birth, meaning that she was 4 when she was impregnated. Now, obviously, this is not a good story because we know how a 4-year-old girl gets impregnated, and it's not through consent. This woman is still alive, though. She lived in Peru. She lives in Peru. And her daughter were raised as siblings until they were 30 or 40, in which case the story came out and it was proved. And no, that she doesn't remember who the father is. I think we can all guess it's either her dad or another male relative or someone who had access to her, unfortunately. But what's also kind of interesting about this case is that's also the youngest documented case of a precocious puberty ever. The earliest onset of puberty that we've ever seen. Now, has this happened before in history? Unfortunately, yeah, probably, right? This happened in a third world country, so this was without the benefits of modern medicine. So the chance that this has happened before in history is likely, right? With 10 billion people, with everyone that's ever lived, probably 12, 13, 14 billion people, this has probably happened a handful of times. But it kind of takes a bunch of combinations of factors for this thing to come together, a bunch of terrible factors for this to happen. For one, if someone, more likely women, undergo sexual activity at an early age, they're more likely to develop their puberty functions earlier than average. It's just kind of a thing that we see time and time again, unfortunately. But while this isn't necessarily a fun fact, I think it's definitely an amazing fact, right? It just kind of lets you know the earliest it's ever happened that we've documented. Now, does anybody want to guess how old the oldest mother to give live birth was? And actually, I don't know that it was live birth, but the oldest mother to carry a baby to term and then deliver it. 79, a little high. She was 74. But what's really interesting about this is if you Google this or Wikipedia it, you'll find that there's about 15 women over the age of 60 that have given birth, live birth. So we're talking about a pretty amazing span of years for all of these people. You know, what's also interesting about all that is the youngest grandmother that we have documented is older than you'd expect, given all those other numbers. She was 23 years old. This was a very poor woman living in Romania. She ran away from home and had a kid when she was 11. And then, you know, like mother, like daughter, her daughter had another kid when she was like 11 or 12. So she was a grandmother at 23 years old. Holy moly. Now, is that the earliest it's ever been? I mean, realistically, probably. That's probably about the youngest it could be. Because this case of this super precocious pregnancy or super precocious puberty, that's unlikely to happen 2 times in a row. What was the youngest grandmother ever? Probably in her 20s. I doubt that she was in her teens. We'd have to have quite a few factors come together for that to happen, but it's definitely possible. The thing is, we don't really know through most of human history, right? So, OB and gynecology. Obviously, OB is baby making. Gynecology is just the female reproductive organs. But obviously, these go hand in hand. Most obstetricians are also gynecologists. My girlfriend works for an OB-GYN. Actually, she works for 2 doctors. So we're going to talk about the female anatomy. We talked a little bit about that yesterday. The ovaries, obviously the same things, the testes. The fallopian tubes equate to the, not the epididymis, but the vas deferens. In males, the epididymis is a different structure. The uterus equates to the prostate, and then the vagina and clitoris become the penis. The cervix is that tight closure between the uterus and the vagina. This is closed for most of our lives. It only opens up to expel the insides of the uterus when we do not get pregnant or when we are ready to give out the baby. All right, so here's some photos. Obviously, I'm sure you guys have seen this before. We all kind of understand the general idea of the female gynecology or the female anatomy. Now, here's a couple interesting things about this that you may not have known. The ovaries are not connected to the fallopian tubes. Okay, this isn't like a hose that you attach up and screw into the wall socket of the ovary. No, in fact, the fallopian tubes are not touching. There's an open space between them and the ovaries. Most people don't know this. Now, this is why when we release eggs from the ovary, so you see all these little cilia that are kind of these hairs that direct the fluid in there. So we're more likely to pull things into the fallopian tubes. However, we've talked about, or we're going to talk a little bit later about ectopic pregnancies. You guys are probably most familiar with an ectopic pregnancy. An ectopic pregnancy does not necessarily mean it implants in the fallopian tube. Ectopic pregnancies mean that we have implanted anywhere outside of the uterus. Sometimes eggs can implant in the ovaries themselves. Sometimes eggs implant in the fallopian tubes. This is the most common cause of ectopic pregnancies, most likely thing to happen. But occasionally, those eggs will get released from the ovaries and they will become impregnated by the sperm, and then they will implant somewhere outside, usually on the outer walls of the uterus, like here. Now, the outer walls of the uterus are similar to the inner walls of the uterus, but what they're lacking is that acidic nature in here. When we become pregnant, we become extremely acidic within the uterus, kind of like similar to how our stomach gets very acidic. As far as other structures we're not talking about here, the mammary glands, which we'll talk about. When I was young, and this will show a little bit of my ignorance about what I used to know about medicine, I used to think that the nipple was kind of like a nipple on a binky, or like on a baby's bottle, in that they're shaped kind of the same way, and there's like one hole in the end. That's not the case. There's 15 to 20 mammiferous glands coming out of the nipple that shoot out like a wonky shower head. It's not like one solid stream. And I know obviously that might be obvious news to you guys now, but I went a lot longer in my life than I'd care to admit not knowing that. So if you didn't know that, now you do. So the ovaries are attached to the posterior spine by a large ligament called the mesovarium. Your ovaries are attached to the spine. Everything's held in place with ligaments. So what's interesting is ligaments don't always attach bone to bone, right? They don't. Ligaments attach other structures as well. They can attach organs to bones, different than the way that tendons attach muscles to bones. I know that can be confusing. I don't blame you. No one asked me what we should name things when they were coming up with stuff for the human body, all right? I would have changed the names of quite a few of these things to things that make a lot more sense. But hey, the things are named what they're named. And unfortunately, a lot of what we do in medicine is because of, that's just the way it's always been done. For example, we didn't really go over this, but there's this concept called VQ mismatch. Maybe you guys have heard that before. It has to do with ventilation and perfusion mismatch. In other words, what you're breathing in and the way that it's perfusing at the cells isn't working out, right? Something's happening to get in the way. Now, V stands for ventilation. That makes sense. And Q stands for perfusion. Why is that? It actually took me a lot of looking up to figure it out, because like everyone I'd look up, there's like, yeah, V stands for perfusion, no problem. Or sorry, Q stands for perfusion. But in case you guys are wondering, where does that come from? It comes from the French word quantité, or the number. So that's how they say perfusion in French. They don't use perfusion, they use quantité as a different kind of word. And then for some reason, we adopted that in English. And now everybody says VQ mismatch rather than VP mismatch, which would probably make a lot more sense. But again, nobody asked me what we should name things in medicine. So things are named what they're named. So, two other ligaments hold the ovarian arteries, veins, and nerves in place with suspensory ligaments. Each ovary has a dense outer portion called the cortex and a loose inner portion called the medulla, the same as in our adrenal glands, right? The inner portion is the medulla, the outer portion is the cortex. I know cortex makes you think of the center, right? But unfortunately, that's not how it works. Inside the cortex are multiple small pockets, follicles, each containing an oocyte or premature egg. By the way, you are going to change names multiple times before you even become a fetus. You start off life, well, I know that the sperm comes together with these eggs to form a life, but the majority of the genetic material comes from the egg, not from the sperm. This egg actually gives, I think, 75% of the genetic material towards the fetus. Does that mean that 75% of your DNA is from mom and not dad? No, not necessarily. Sperm are packed full of DNA. They are not packed full of all the information on how to become a fetus, how to form properly. A lot of that is housed within these eggs, these oocytes. And you start at life as an oocyte. You then become an ovum, and then you become a zygote, and then you become a morula, and then eventually you'll become a fetus. So you're going to change names multiple times throughout this whole process. But you start off as an oocyte. Now, women have about 2 million oocytes, or unripened eggs, and they have those when they're born, and that's all they'll ever have. So ladies, you only have 2 million chances. You can only give birth to 2 million babies at the ultimate limit. That hasn't happened yet. And by the way, that's absolutely impossible, obviously. 2 million eggs is way more than we'll ever need. Most women will only release about 400 eggs in their lifetime. So if you're following along at home, that means that most women will have 400 periods in their lifetime, 400 menstrual cycles. Obviously, that number can go up and down depending on how many times you get pregnant. And also it can go up and down depending on how regular a menstrual cycle is. As you guys are probably aware, menstrual cycles are not always regular. In fact, people that have a perfectly regular menstrual cycle probably don't account for a huge portion of the population. A lot of women can go months in between having menstrual cycles, especially with the advent of oral birth control or all these other versions of birth control, right? There's injections, there's inserts, there's dozens of ways for birth control to affect us. Normally, this causes chemical releases in the body that will prevent you from having a period. So women like that probably are not going to have 400 periods in their life. But there will also explain why some women get pregnant and go all the way to giving birth without realizing that they're pregnant. This is not a rare occurrence, okay? It's happened to me, not to me, but I've delivered a baby that we showed up on scene for abdominal pain and vaginal discharge. And I'm talking to her and I say, is there any chance you're pregnant? And she goes, no. And I'm like, looking at her and I'm looking at things and I'm looking at what's happening. And I say, are you sure? And she's like, yeah, I'm pretty sure. I'm like, are you pretty sure? Or are you definitely sure? Because I think you might be pregnant and giving birth right now. And that's when she realized what was going on. Or that's when she realized maybe that was true. She had not had her period in 9 months, but she had an irregular period. She was on birth control. So there was no reason that she would have had her period. The weight gain associated with pregnancy is sometimes can be as little as 15 to 20 pounds. And so gaining 20 pounds over a 40-week period, which by the way, it's a lot closer to 10 months than it is to 9. But we always kind of like to say 9 months. But realistically, it's 40 weeks, which is about 9.5 months. And also there's this chance that, some people just hide it better, right? The food cravings and all the effects you feel during pregnancy are different from woman to woman. this happens with enough regularity that they were able to make a TV show about it, right? I didn't know I was pregnant. So, I mean, I've seen it once before in my career, which is why I know that it's probably a lot more frequent than you would think. That seems terrifying to me as a man, right? I never have to worry about a baby accidentally sliding on out of me just because I wasn't paying attention. But, you know, I also think that in general, and this was definitely the case with my patient, I don't like to paint with a broad brush or stereotype, but I think the women who get pregnant and don't realize they're pregnant, they all have one commonality, which is, and don't take this the wrong way, but they're not the brightest crayons in the pack, right? I think it's easy for us to not pay attention to our bodies. And I always try to remember the average person doesn't know anything about medicine, right? They don't really pay any attention to their bodies. They don't really understand what we put into our bodies mentally and physically affects the outcome. They don't always understand all these concepts. So there are a few commonalities between these people, but again, it can happen to pretty much anyone. There's a space between the ovary and the opening of the fallopian tube, like I was saying. So sometimes, the ectopic pregnancies can happen outside of the uterus, outside of the fallopian tube, somewhere in the abdominal cavity. Once inside the tube, the oocyte is transported by cilia, which are little, they're like little, not like kind of like hairs, but they're not hairs, right? They're little extensions of the organ that help flow things inside. Again, kind of like the tendrils of a jellyfish. Uterus, when it's not being it's not holding a baby, is about the size and shape of a pear. It's oriented in the pelvic capillary with the fundus, the top, directed upward and anteriorly. The inferior portion, the cervix, is the opening through which menstrual blood will be passed in the event that the oocyte is not fertilized. By the way, you're really only fertile for about 1 day, sometimes as little as 6 hours. And this is exactly 2 weeks following the menstrual cycle, assuming that you're following a regular menstrual cycle. So from the period when you start start bleeding, having your menses, 2 weeks after that is when the oocyte will be released and will be the most fertile. This can last up to 2 to 3 days. Sperm can last inside of you for 2 to 3 days as well. So there's a little bit of overlap to try and increase the likelihood of this happening. But realistically, we're not fertile as often or as long as you would suspect. After that egg is released, it's no longer going to be fertile. It's no longer going to be implanted. And 2 weeks after that, the body's going to just flush it on out. Now, does that mean you can rely on that to not get yourself or your girlfriend pregnant? No, I would not rely on that. I would rely on other means. The vagina will stretch greatly for the birth of the baby. I think this is pretty well understood. The walls of the vagina secrete substances that protect the developing fetus. It becomes acidic during pregnancy. The acidity prevents bacteria from growing that might enter the uterus. The perineum, not to be confused with the peritoneum. The perineum, also colloquially known as the taint, is the area of the external female and male genitalia between the rectum and the genitalia, or the vaginal opening in women. Men have a perineum as well, though. In some cases during delivery, this might be cut to allow for delivery of baby's head and prevent tearing. Again, this is when the mom is too small and the baby is too large. I've seen a woman get cut once. We watched the delivery in the OR, in the delivery room, and baby was trying to get out, and the doctor's like, okay, I'm just going to make a decision. She just took out a pair of surgical scissors and just kind of cut just a little bit along the perineum. Baby came out, and then she sewed mom back up really quickly. Now, that does happen, and it's better if you can cut it than if it gets ripped open due to a precipitous delivery or a very fast, explosive delivery. Obviously, anything that gets ripped is going to cause more scar tissue than if we cut it with surgical tools and then sew it up right away. Your genitalia gets a huge flow of blood, okay? Huge flow of blood at all times. So genitalia heals really well. Ask me how I know that the genitalia gets a huge flow of blood. Well, I'll tell you, I treated a guy once who broke his dick in half. And not only did he break his dick in half, but the woman he was engaged in sexual intercourse with, who broke his dick, was also had a genital piercing, specifically on her clitoris. And when she was on top and she goes up too high, the penis slides out. She goes on top of it, bends it, and breaks it. Okay, this is the same as a muscle tear. And then her clitoris piercing got caught on the under artery of his penis and then ripped it open. And this guy had massive hemorrhagic bleed coming out of his penis that happened almost instantaneously during sex. This was a real call I went on, and I showed up, and it was literally just blood everywhere in the bedroom and all the way into the shower. The woman's sitting on the couch crying, and then me and all these firefighters show up, walk into the shower, and I'm like, "Hey, dude, what's going on?" And he goes, "My dick." And I say, "Yeah, come on out. Let's take a look." He comes on out, and he's holding it in his hands, and it's literally the only way I can describe this is 2 pieces within 1 sock, if that makes sense to you guys, if you're picking up what I'm putting down. And it was bleeding profusely. Now, the number one thing in trauma, Phil will tell you, you got to stop that bleed, right? So no one's ever taught me how to stop bleeding on a dick, but I can guess. So I literally just took an abdominal pad and I tacoed his dick with it, and I wrapped it up real tight with some Coban, and that stopped the bleeding. But obviously this guy's in an incredible amount of pain. But here's the funniest part about this story. We get him onto the gurney, and I get him in the back of the ambulance, and I'm saying to myself, all right, this guy is getting the full dose of morphine because I know, or I can guess how much this hurts. And I put the tourniquet on his arm to make his veins pop out. And while I'm looking for a vein, the guy looks at me and he goes, "Hey, dude, do you have to put that thing on? It really hurts." And I stop what I'm doing and I look at him and I'm like, are you serious right now? The tourniquet hurts? Would you say that that's the worst pain you're experiencing? He goes, "It really hurts, man. Can you take it off?" I said, "Sure." I took the tourniquet off. I got the IV without the tourniquet, but I'll always remember that. Like, your dick is broken in half and you're going to complain about a tourniquet and an IV to get morphine? Really? Like, weird priorities. One of the weirder calls I've been on. Anyways, you better believe that I was terrified to have sex after that. To this day, I don't do reverse cowgirl. Okay. That's a lot of information, but just full disclosure, that's what they were doing when this happened. Okay. I know you guys were curious. Reverse cowgirl. Yikes. By the way, you can recover from that. I know that's the other thing all you guys are curious about. Can you recover from that? Yes, it's the same as any muscle tear. It'll take about 6 months. Normally muscle tears might take a little longer than that, but this is a very well blood supplied muscle. So goodness gracious. Let's talk about the mammary glands. So that's a personal favorite of mine. Female breasts begin development during puberty, 10 to 13, under the effects of estrogen and progesterone. The onset of puberty is known as menarche. The end of puberty, or I should say the end of the reproductive cycle in women, is known as menopause. Each breast has 15 to 20 glandular lobes, which will have lactiferous ducts. Each duct has secretory sacs, I don't have trouble with that word, called alveoli that secrete milk during nursing. Kind of similar to the alveoli in our lungs. This is just a word for the structure, though. Like I say, if you were to give the breast a good squeeze and able to get milk out of it, pardon the crudeness of me describing this, but it will shoot out like a wonky shower head. That's the best way I can describe it. Menstruation is the normal periodic discharge from the uterus of blood and tissue, about 25 to 60 milliliters. This can vary from woman to woman, though. Cycle lasts 20 days. This is also known as the lunar cycle. By the way, does it actually have to do with the moon? We don't fully know. Lots of animals have lots of different cycles. So if the moon was really having an effect on our menstrual cycle, then it seems like it would have an effect on most animals' menstrual cycles, right? And they would all have these cycles that last 28 days, but that's not the case. And it's also not the case. All animals gestate and have lunar cycles at different ranges. So why does it happen to be 28 days in women, the same as a lunar cycle? Just a coincidence, honestly, just a coincidence. By the 4th prenatal month, the ovaries contain about 5 million cells. Of these, oocytes develop. Oocytes are immature cells which can develop into a fetus. At birth, we have about 2 million primary oocytes. Only 400 are eventually released from the ovaries, like I was saying. Oocytes are contained within a follicle. Remember we talked about those sex hormones released from the pituitary gland, follicle stimulating hormone, and luteinizing hormone. This all helps us generate these structures. Follicle forms a bump. The ripened follicle is called a Graafian follicle. It ripens faster and it can be accommodated by the ovarian wall. It swells and ruptures through the wall of the ovary, enters the space between the ovary and the fallopian tube, free floating. The oocyte moves out of the follicle and floats into the fallopian tube. It's called ovulation. After ovulation, the follicle is transformed into glandular structure, corpus luteum, containing progesterone and estrogen. If the oocyte is fertilized, it'll begin to secrete another chemical called chorionic gonadotropin. And remember, this is the chemical that's going to cause morning sickness and also this very terrible disease that can affect some women during pregnancy called hyperemesis, which is, as the name implies, throwing up so much uncontrollably. Not a pleasant thing. Unfortunately, we need chorionic gonadotropin to help the fetus develop, but it has lots of very unfun effects for the woman. Sorry, ladies. If the oocyte is not fertilized, the corpus luteum disintegrates. In other words, you're going to have your period. The levels of progesterone and estrogen drop and menstruation occurs. In the interim, hormones in the pituitary gland are prepping the interior of the uterus for implantation of the oocyte, which is now an ovum. Remember, your name is going to change. Next step, zygote. The walls of the uterus thicken and become lined with a rich layer of blood vessels for the ovum to latch onto. If it's fertilized, it's going to find a nice location, latch on, and then begin to form a placenta. If not, the uterine contents are evacuated and then the cycle will start all over again. Now, normally, it's able to clean itself out very efficiently. This is because of the contractions, right? The cramping associated with menstruation is what helps clean out the inside of the uterus, because we need it to be completely cleared out, or all that tissue will become necrotic and you can become infected. This is not normally a problem with menstruation. Some women it can be, but most women are able to menstruate just fine. When this really becomes a problem is if we have a miscarriage or an abortion is more likely to cause this, and also ectopic pregnancies as well. What does that mean? It means that there's tissue left behind. And how do we deal with that? We need to perform a surgical intervention known as a D&C. It might not be considered a surgical intervention. I honestly don't know. What we do is we dilate the cervix, that's the dilation, and the C stands for curettage, which is, again, another French word for lack of a better phrasing, for scraping out the inside of the uterus. All right. And we will essentially dilate the uterus so we have access to it, go inside and scrape down the walls and clean them out of any necrotic tissue so it doesn't become infected and the woman doesn't become septic. Again, not a common procedure, but sometimes needs to be performed after abortions or after miscarriages. Gynecological emergencies. PID, ruptured cysts, cystitis, dysmenorrhea, Mittelschmerz, endometriosis and itis, ectopic pregnancies, and vaginal bleeding. We're also going to talk a little bit about sexual assault and traumatic vaginal bleeding. Pelvic inflammatory disease affects about 1 million women, is responsible for quite a few hospitalizations, causes infection of the entire female reproductive system. By the way, guys, before we get too much into this, here's what you really need to know about pregnancy complications. Most of them, the chance of killing the mother is low, except for ectopic pregnancies. Now, The big risk for a lot of these disease processes is infertility, which is definitely a very real problem, but it's not necessarily a life and death thing for the mother, but it is a life and death thing for her reproductive abilities in many cases. So one of them is PID, pelvic inflammatory disease. It's caused by sexually transmitted bacteria, gonorrhea, chlamydia, or other ones. Infection travels from the vagina to other structures. How do you recognize this? Diffuse lower abdominal pain, low-grade fever, vaginal discharge, dyspareunia, which is pain with intercourse. And another thing, which is a big sign, which is called the PID shuffle, pain on ambulation. So we're going to have trouble walking normally, so they tend to shuffle their feet a lot. Pain when they're having sex, sometimes pain when they're urinating as well. In really extreme cases, again, hysterectomy can happen from this. This can lead to infertility. It's not guaranteed to, but it can. There's an inflamed pelvic. All right, so this is an inflammation of the fallopian tube or the uterus. Or the ovary or the uterus. Ovarian cysts, again, some people are just predisposed to these and some people are not. Ruptured ovarian cysts are true emergencies, depending on how big they are. They can cause severe internal hemorrhage. A cyst can form on the surface of the ovary and is usually fluid-filled. It causes abdominal pain due to its rapid expansion. It can also cause torsion or twisting of the ovarian pedicle that will lead to ischemia of the ovary or ovarian rupture. Again, anytime something gets kinked, we're cutting off the oxygen flow to it. The uterus, like I said, is getting a huge flow of oxygen at all times, especially if we're pregnant. All right. So some patients with a ruptured ovarian cyst have vaginal bleeding or late missed periods, localized one-sided lower quadrant pain. Also, sometimes signs of peritonitis. We can test peritonitis with this test called the Markel heel drop test, where you have the patient stand on their feet, and then you have them go up on their toes and then drop quickly to their heels. And if that increases the pain, it's very likely that they have peritonitis or inflammation of the peritoneum. There's the ovary with a cyst inside of it. This can appear in quite a few different ways. Cystitis, bladder infection, UTIs. Severe UTIs can also lead to infertility. Both sexes can get cystitis, but it's more common in women due to the short length of the urethra. The frequent urge to urinate, which produces only a small amount of urine with accompanying bladder spasm. Chills, fever, abdominal pain, strong smelling urine, burning on urination can be caused by structural abnormalities, which can happen in kids, or it can happen due to hygiene concerns, usually in the elderly. Cystitis can also be caused by pressure on the urethra or the prostate in men. Can be caused by indwelling urinary catheters, which can be very common in nursing home residents who are bedridden. In fact, any of you guys that have worked in hospitals or in nursing homes know that catheters cause infections at really high rates, which is actually a big problem with the catheters. Most women will probably experience a UTI within their lifetime. If you do experience a UTI, unfortunately, that means you're at a higher risk to experience more in the future. Not because one UTI makes you more susceptible to UTIs, but just because the structures in place, we know it can happen once, so the chance that it's going to happen again is higher. We have a lot of over-the-counter medications available to treat this, however. Next one is dysmenorrhea, which is just a catch-all term for pain during menstruation. Now, pain during menstruation is expected, right? The cramps, the abdominal pain, the bloating, all of those things go together. But that's called menorrhea, right? Pain during menstruation is expected. This is dysmenorrhea. This is abnormal pain, out of the ordinary. The woman will know. Other symptoms are headache, nausea, diarrhea, dizziness, back pain. Severe cases might be chills, nausea, vomiting, and syncope. Usually happens in women who are not sexually active and who have not had children. Pain is possibly related to contraction of the myometrium, which is the myo, again, is muscle, and the metrium is in the uterus, uterine muscle layer. Also caused by infection, inflammation, or IUDs, which are birth control implantation devices. I think it stands for intrauterine device. Mittelschmerz. This is German. Everyone loves shouting things in German. In fact, shouting Germans they're just very comfortable people to be around, right? Everybody loves a German who's angry and shouting. Mittelschmerz means middle pain. May occur from the rupture of different follicles, graphene follicles, right or left lower quadrant plane, lasting a day to a day and a half. Occurs in the middle of the menstrual cycle after ovulation. This is why we call it middle pain, right? Right after the ovulation, there's a rupture, and that's causing this pain. Patient might have slight vaginal bleeding, low-grade fever, not life-threatening, but it can indicate more serious complications, probably relating to chemical imbalances. They need to seek medical attention to rule out other causes like ectopic pregnancy and appendicitis. Endometriitis and endometriosis. Endometriitis is the inflammation of the uterine lining. Itis, obviously, inflammation. Caused by infection, retained uterine contents. Remember, this is what we need a D&C for, dilation and curettage. Retained placental tissue may affect the uterus and fallopian tubes. If untreated, can lead to sterility, sepsis, and death. Like I say, you got to clean out that uterus. We need a clean slate every single time because that tissue will become necrotic. Endometriosis is a gynecological condition characterized by abnormal growth of endometrial tissue outside of the uterus. Fragments of the endometrium may be pushed out of the uterus into the fallopian tubes and even into the abdomen. Remember, during that, in that free floating space between the fallopian tubes and the ovaries, they can attach to other structures and begin to grow. In fact, if we have endometriosis, it's actually possible, and this has happened, that we can give birth to a baby that does not implant inside the uterus. People have had ectopic pregnancies that have implanted. Ectopic pregnancies with endometriosis means that they have enough uterine tissue outside for the egg to implant on, and people have actually carried a baby to term outside of their uterus. Yes, that has actually happened. But then again, pretty much everything has happened at this point in history. Is that rare or likely? Absolutely not. Most of the times, that's not going to be a viable pregnancy, but it's happened. Literally everything in medicine has happened at least once. Everything. All right. Average age of women with endometriosis, again, is going to be a little older towards the end of their reproductive cycles, 37. We expect women to hit menopause, which is the true end of their cycle, at about in the 40s to 50s. It varies from person to person. And ectopic pregnancies, we went over these. Anything outside of the uterus may develop in the fallopian tube, most common, ovary, cervix, or even the abdominal cavity. We'll usually discover these in about the second month of pregnancy when the developing fetus becomes too large for the structure where it's implanted. Most of these women will not know that they're pregnant. They may have had negative pregnancy tests. If the fetus is not implanted in the uterus, the patient may have had their menstrual cycle as usual. But we're going to notice severe pain. So by the way, anytime you get a woman in any reproductive age with abdominal pain, you need to ask her, hey, is there any chance you might be pregnant? Peritonitis with subsequent sepsis may develop if there is a slow bleed. The treatment is surgical removal of the fetus, placenta, and any damaged tissue. Hopefully, we don't have too much damage to the fallopian tubes to cause infertility. However, the good news is we have 2 fallopian tubes. So we still will have a chance. It won't necessarily guarantee infertility, but it can. The problem with this is, again, that blood flow, if this grows too large and ruptures, we can have massive internal hemorrhage. Vaginal bleeding, the most common source of vaginal bleeding is menstruation, obviously. Like we were saying, 25 to 70 milliliters of blood and tissue. But there's other things which can go on here. Not all bleeding is menstruation, so don't assume it is. the patient is passing clots with blood, it is not normal. Ask about the number of pads the patient has used. This says retain the pads for the ER. I don't think that's absolutely necessary. You can definitely ask the woman how many pads she's been using. How many pads does she normally use during a menstrual cycle? Is this a really heavy flow, a really light flow? How does it compare? Now, you guys are mostly guys, so I don't expect you to know this, but flows can vary, right? Which is why if you've ever looked at tampons or pads being sold in the supermarket, they come in ranges, right? You'll have some that is like light, medium, and heavy flow. This also depends on the day of the cycle we're on. Usually the heaviest bleeding occurs on the first and second days, and then it'll get a little lighter and lighter as time goes on, usually. Traumatic causes of vaginal bleeding include straddle injuries, right? So anything where there's kind of a force going up into that passageway, if you know what I mean. Blows to the perineum, blunt force to the lower abdomen. It can also caused by pelvic fracture, causing internal injury, sometimes due to abortion attempts, not necessarily surgical or doctor office abortion attempts, but home abortion attempts, which I have run on once before in my career, where a woman successfully was able to get up inside of herself and pull twin fetuses out. That was one of the crazier calls I've been on as well. And I think about it, I've seen on quite a few calls that are definitely out there with regards to how people have handled their medical situations. Sexual assault. Unfortunately, this is extremely common. Not always to pregnant women, but to women in general. In fact, the very unfortunate statistic is that 1 in 3 women will be sexually abused at one point or another in their life. Is that number accurate? Unfortunately, it is. Now, we can't really guarantee it because also, unfortunately, is a lot of these go unreported. By the way, it's not just women who suffer from sexual assault. 1 in 10 men will experience sexual assault at one point in their life. That number is also probably much higher, but there's definitely more of a stigma for men to report this. There's also a stigma for women to report this. Now, thankfully, we're getting a little better as a society in recognizing these claims and realizing that there is definitely a problem in the way that we are sexualizing people. However, I don't think that we're any closer to forming a permanent solution to that, because we've been sexualizing people our entire existence. It's just been more prevalent than it's ever been before. So unfortunately, yes, 1 in 3 women will probably experience either rape or molestation or some sort of sexual assault at some point in their life, usually when they're under the age of 20. Only 15% will eventually report it, which is a big part of the problem. First, you need to care for the patient as you would any other patient, with the emphasis on addressing their life threats, right? Hemorrhage, airway, breathing, circulation. Modifications might be made for their physical exam, privacy, and confidentiality. The piece of advice I can give you is ask for a female paramedic or a female EMT to come and help assess the patient. Ask her if she's comfortable with you, if you're a male, because most of us are males. I've been in this situation before, and I've asked her, I've said, do you want me to take you to the hospital, or would you like me to get a female paramedic to get you to the hospital? And if she says yes, I'll get on the radio, I'll ask for a female paramedic, I'll call my supervisor, explain the situation. They should have no problem with that. They might bring an EMT in if they don't have a paramedic available, but they'll find someone. All right. I usually have a female partner. It's just kind of my preference to have a female partner, not because I like working with women over men, right? There's great EMTs that are men. There's great EMTs that are women. The reason is because of things like this. For one, having a female with you can help de-escalate certain behavioral and psychological problems with patients. They're much less likely to freak out if someone reminds them of their mother or sister, rather than if it's a bunch of tall white dudes standing around with blue uniforms and badges on, which is unfortunately is the case very frequently in this field. women help to moderate some of those feelings for some of these patients. So that's always helpful. That's why I prefer female partners. Don't question the patient in detail about the event. That's not really part of your report. You need to report the factual stuff. They're going to go to the hospital and they're going to talk to counselors, therapists, things they need to in order to get the story out there. We try to keep them from changing. If they do change their clothes, we try to have them bring them with them. Ideally, we would have them stay in their clothes and not shower. Okay, because that's going to wash away evidence that we might help this whole situation. Other than that, you're just going to need to follow your best judgment and remember that emotional support is what's called for in this case, not medical support. So it's a tough thing to talk about, but unfortunately, it's going to happen. So pregnancy and conception. So real quick, going over that process one more time. Oocytes expelled from the ovary and travels to the fallopian tube where it meets up with the traveling salesman. Sperm enters the membrane and immediately prevents any other sperm from entering in. Nuclei, the sperm, the ovum will fuse. Then it will become a morula. Sorry, it becomes a zygote, begins a number of cell divisions. Bundle of cells becomes a morula. The morula has a layer of cells in the outer wall called trophoblasts. This is the outside. This is what's going to help it implant within the uterus. Rolls out of the fallopian tube, moves down to the uterus, and it finds a nice thick portion of the wall, and it implants there. The trophoblasts attach to the wall, start to dig in and make contact with maternal circulation. Implantation occurs 7 days after the oocyte is fertilized. As soon as the trophoblasts implant, there's a slight discharge of vaginal blood, sometimes called spotting. As soon as it occurs, a plug begins to form in the opening of the cervix to prevent bacteria from getting in and from anything getting out. This plug will last until the water breaks in an ideal situation. The placenta is a flat, round organ that's composed of intermeshed fetal and maternal materials. It is the organ that connects the mother to the baby and performs a number of functions during the pregnancy. O2 and CO2 diffuse through the placental membrane, maintaining homeostasis in the developing fetus. So the baby does not have any gas exchange happening in their lungs. They have perfusion happening at the cellular level of their body, but all of the breathing, quote unquote, that they do happens through the placenta. Babies do not use their lungs until they come out of the tube. Placenta also carries hormones and nutrients as well as the oxygen to the baby. Baby's blood and mom's blood do not mix. Baby and mom can have different types of blood. All right, the placenta forms an umbilical cord. This is sometimes as little as 6 inches long, and sometimes it's as long as 2.5 feet. Yeah, 6 inches to 3 feet long. It can be very long. Fetal circulation is unique due to the fact that the fetus in utero is not an air breather. We are living in a completely aquatic environment for the first 40 weeks of our lives, not using our lungs. There is still blood flow to the lungs, right? Because like all cells of the body, they still need oxygenation. So it's not that the lungs are empty. The lungs are still filled with blood, but no gas exchange is happening there. The foramen ovale and the ductus arteriosus allow blood to bypass the lungs of the fetus. So there's a couple different structures in fetal circulation that allow for the placenta to provide the oxygenation rather than the lungs. The foramen ovale is another one. It's all opening between the two atriums. So we bypass the ventricles. Ductus arteriosus connects the aorta and the pulmonary artery. So blood high in oxygen from the placenta enters the left side of the heart instead of the right. So there's a couple differences in fetal circulation. All of this is going to remain in place until we come out of the womb, at which point it's going to start to close up and start to heal up. However, obviously, lots of things can go wrong with that, which we'll learn about. Amniotic sac is a fluid-filled sac that surrounds and protects the fetus. At term, it's going to contain about 1 liter of amniotic fluid. In other words, when your quote-unquote water breaks, you should release up to 1 liter of amniotic fluid. By the way, the water doesn't always break. Sometimes babies have been born still in their amniotic sacs, kind of like this, looking like big old dirty jelly beans. All right, guys, let's take a little break. It's 10:30, so let's take a break. Come back at 10:45. It's like 12 minutes or so. So short little break. All right, guys, I'm back. Let's get back into it without too much more ado. All right. Maternal changes in pregnancy. The genital tract, the uterus is going to increase in size from about 70 grams to 1,000 grams by full term. The uterus is going to triple in size and weight. The uterus is going to get bigger. Okay, blah, blah, blah. We all know that. The cervix will develop a bright purplish color called Chadwick's sign due to increased blood flow. Vaginal mucosa is thickening. pH in the vagina becomes more acidic, aka the pH lessens, to keep the vagina free of pathogens. Bladder, the mother's going to experience urinary frequency due to enlarging of the uterus, pressing up against it, less room for the bladder to expand. The breasts are going to become a lot more tender as the areola darkens and milk production begins. Morning sickness and nausea are the result of, once again, chorionic gonadotropin. The GI organs are displaced upward and laterally, making the mother more prone to heartburn and aspiration. The liver is moved around. Everything's moved around because of this giant freaking baby. The baby is taking up a lot of room. This is also going to affect maternal circulation. Keep in mind, we talk about the positioning left lateral recumbent, meaning laying on your left side. Why is that a consideration? Remember that the vena cava dumps that deoxygenated blood into the right atrium of the heart. If we lay on our right side, when everything else in our abdominal and thoracic cavity has been compressed, we're going to reduce the amount of blood that's able to return to the heart, thus increasing the likelihood of varicose vein formation, as well as the reduction of preload into the heart. This is a problem. So we always try to lay mom on her left side, not on her right. Obese patients as well. GI motility is decreased, leading to prolonged emptying. The gravid uterus pressing on lower abdominal organs can lead to hemorrhoids. Heartburn and constipation are common. It's almost like we're not very well designed to do this, right? And yet we do it all the time. Elevation of the diaphragm displaces the heart to the left, so this is going to show some different EKG changes, right? Cardiac output increases by 30% by the 34th week of pregnancy. Why does this show different EKG changes? By the way, let's talk about this. All an EKG is measuring is the direction of electricity flow, okay? If an EKG change is positive or negative, we're just looking at the way that the shock is shooting one direction or the other, all right? That's all we can really measure. So obviously, if the heart's moving slightly, it's going to slightly flatten out these waves because the heart is slightly off to the left. Just like anyone who naturally had their heart at a more extreme angle would also show slightly more flat showings of this. Someone asked me the other day, why do we see changes in like the P wave? Remember, for the wandering atrial pacemaker, sometimes the P is up, sometimes the P is down, sometimes the P is flat. Why is that happening? It's because the atrial pacemaker is wandering, literally. So the thing firing, the pacemaker, is firing from the bottom, it's firing from the top, it's firing from the middle. We're getting different sensory inputs. That's why we see these changes in electrical conduction in the heart. Total blood volume increases by 30%, plasma by 50%, leading to something called dilution anemia. The blood does not have the same hematocrit that we would expect it to. Blood pressure decreases, but it increases to pre-pregnancy levels by term. But during that second trimester, expect 10 to 15 systolic point drop. Enlarged uterus interferes with venous blood return from the legs, leading to varicose veins. Slight edema is also possible. Supine position may compress the inferior vena cava. Again, this is why we do left lateral recumbent. Increased plasma volume reduces hematocrit. That's what I just said. Leukocytes increase in number. Leukocytes are white blood cells. Fibrinogen levels increase by 50% due to estrogen and progesterone. In trauma, this is going to lead to excessive clotting, and then that condition known as disseminated intravascular coagulopathy. Excuse me. Or clotting within the veins. The respiratory system tidal volume is the total amount of air we can breathe. And minute ventilation is tidal volume times respiratory rate. This is going to increase because we're breathing faster, because not only do we have to perfuse all of our own cells, but we also have to perfuse all of these new cells, right? Everything's increasing by about 30%. Functional residual capacity decreases by 25%, though. This is another reason why it's increasing so much. Normal weight gain of about 20 pounds. This can vary. more for twins and triplets, right? Increased water retention, metabolic and calorie demand increased. They're going to be needing more food. We're eating for two, right? We always say that, but it's literally true. Maternal gestational diabetes may occur from an inability to metabolize carbohydrates due to this increased caloric demand. Fetal demands for calcium may deplete mom's stores unless prenatal vitamins are taken. This is why prenatals are so important. Remember, though, the most important prenatal vitamin is folic acid. How do we manage a pregnant patient? There's a bunch of questions you guys need to know to ask. All right. First is para and gravidity. This is number of pregnancies and the number of live births. Okay. If we have an abortion, a miscarriage, or the baby is not delivered to term, we don't count it as a live birth. We count it as an abortion or a miscarriage. Doesn't matter. They're both classified in the same thing. The length of gestation, we know their last menstrual period, their expected due date, have they been taking their prenatals, when's the last time you had an ultrasound, who is your OB, and then anything that they're doing in their lifestyle, alcohol, drugs, smoking. We know that these cross the placental barrier and can affect fetal development, some more than others. I had a woman who, the last baby I delivered in an elevator actually was this woman who, when she got pregnant, she stopped injecting her heroin and she started smoking it because she read that that was going to affect the baby less. As far as I can look at information, it doesn't seem to make very much of a difference. Injecting and smoking both bypass first pass metabolism, and both are going to affect the baby. When I was delivering that baby, I honestly did not know if it was going to come out alive. I thought maybe I was going to be delivering a stillborn baby, which I have also done, and I do not recommend it. But that baby came out healthy, pink and screaming, probably one of the healthier babies I've seen. The problem is it's addicted to heroin, which it will need to overcome. But babies overcome that better than anyone else. All right. Has your water broken? Are you having contractions? How far apart are the contractions? Any vaginal bleeding? Any, the water breaking? All of those things are important. Is the birth imminent? That depends. Now, if this is mom's first baby, the chance that that baby's going to come out right after the water breaks and contractions get down to about 3 minutes is not very likely. Most first deliveries take somewhere between 12 and 24 hours, maybe even longer. Some women have been in labor for over 24 hours, 24 to 28 hours. When I was born, I was my mom's first child. She went into labor. Her water broke in the middle of the night. I think it was like 2 a.m., 3 a.m., something like that. She gave birth to me at about 7 p.m. that night. When my brother was born, she went into labor again about the same time, like in the middle of the night, 2 or 3 a.m., or maybe it was even a little earlier than that. She gave birth to my brother right at about noon. So usually this is going to be the case. Second, third babies, every subsequent baby is going to come out a lot quicker because those passageways have already been developed and it's already been proven that babies can slide out of there. So mom's going to be more comfortable with it. So everything is going to move more smoothly. Now, of course, there's plenty of exceptions to that rule. I had a female paramedic took my course a couple months ago, and she told me that her first kid came out in about 6 hours and her next kid took over 20. So again, everything can disprove these rules. But in general, if you're delivering a baby in the field, it's probably not mom's first. All right. I've never delivered a first baby. I've delivered a third baby, a fourth baby. I can't remember what the other one was. And the oldest, the latest baby I ever delivered was mom's 9th baby. Goodness gracious. One thing they tell you to do is to evaluate the uterine size. I don't know how to assess dilation of the cervix. Can't really do that. Evaluate the uterine size. It should be near the xiphoid term. Remember, the xiphoid is that little hardened cartilaginous spear coming down off the bottom of our sternum. You can also inspect the fetus. We should be able to hear heart sounds after 16 weeks all the way up to delivery. It can be fast. 120 to 160 is expected. When babies are born, expect this range of heartbeats as well, right? Babies need to beat faster. They need to breathe faster. All right. If delivery is not imminent, Treat and transport like any other patient. The big consideration here is oxygen at 100%. Give her a non-rebreather, give her nasal cannula, whatever she needs. Now, there's one consideration here. It's very helpful for you to start IV access on this pregnant mom before you get her to the hospital. But there's one major consideration. Where do OB nurses not want you to get an IV on pregnant women? They want you to avoid a certain area for IVs on pregnant women. Anybody have a guess where they don't want the IV? Left arm? Not the arm itself, but specifically a location on the arm. They're okay with arms. It doesn't matter which arm. It's not that they prefer the hand, actually. What they don't want is the AC, the elbow, the antecubital fossae, which are those nice, big, chunky veins right in your elbow pit. That's where they don't want it, because mom's going to be bending. She's going to be grabbing. That's going to be hard for her. They actually would prefer the hand or the forearm. So if you really want to please those OB nurses when you bring in pregnant mom about to give birth, you start that IV in her hand or in her forearm or in her upper arm, but not in that AC. Okay, avoid the AC unless you have no other choice. So that's just a consideration for you guys. Labor and delivery. There are 3 stages of labor. The first starts with water breaking and ends when the cervix is completely dilated at about 10 centimeters. The second stage is full dilation until the baby is expelled. And the third stage is when the placenta is delivered. So again, that first stage of labor, moms may take up to 12 hours. Contractions are just going to start off slowly, 30 seconds long, about 10 minutes apart, and they're going to get closer and closer together. Every time mom's having a contraction, you're going to know, because she's going to stop talking to you and start going, write down the time on the back of your glove. All right. Next time she's having a contraction, write down the time on the back of your glove. Figure out, okay, we're looking at 5 minutes. Everyone after that, time it. Is it still 5 minutes? Are we down to 4? Are we down to 3? If they're down to 3 minutes, it's not mom's first baby and her water breaks, you better get ready for that baby to come on out. All right. Literally, if it's mom's like multiple birth baby and water's broken and contractions are 3 minutes apart, I've seen a baby come out from the water breaking to the baby being out in my hand screaming 1 minute. 1 minute. Not even kidding. Maybe it felt like a minute. It might have been 2 minutes, but it felt like 15 seconds, man. If a woman tells you the baby is coming, you better be ready, okay? Mom knows her body better than you do. In fact, that's a good rule of thumb. All patients are going to know their bodies better than you ever will. So if mom says baby's coming, baby's coming. She may have the urge to push or a bowel movement. She feels like she's going to poop herself. This is caused by pressure of the baby's head on the rectum. Not very likely that she's going to poop herself. Does it happen? Yeah, everything happens. Is it likely? No, it's not likely at all. Very rare. If the female's beginning to crown, the area near the vaginal opening will begin to bulge outward. The presenting part, usually the top of the baby's head, will begin to show at the vaginal opening. Baby's head will continue to be pushed out with each contraction as the uterus decreases in size. All right. Now, here's the thing you guys need to know about delivering babies is at this point, the bus pretty much drives itself. All right. Think of it this way. Most babies were born without a doctor present, without a nursing staff present. Most babies were born like in a cave in the middle of a rainstorm while jaguars were circling around outside. Okay. This is a process which works pretty well on its own, even though I have a lot of complaints with the biological and anatomical structure of the body. Gentle pressure to the baby's head can prevent an explosive delivery, which can tear the mother's perineum and injure the baby. If the mother's pushing too hard, have her pant through the contractions to slow the speed of those. Support the head, but don't turn it. The baby's going to rotate on its own. Check for an umbilical cord around the baby's neck. If it's wrapped, we're gently going to push it up and over the baby's shoulder, or over the baby's shoulder, or up and over the baby's head. If it's too tight for us to move, clamp and cut. Now, I have a question for you guys. We have a bulb syringe in our hand. They always tell us when the baby's head comes out, we need to suction its mouth and its nose. Which one do we need to suction first? The mouth or the nose? Which one needs to be suctioned first? The mouth. That's correct. Now, I have a second question for you guys. Are babies mouth breathers or are babies nose breathers? Both mouth. Babies are nose breathers, not mouth breathers. So if babies are nose breathers, why do you think we suction the mouth first? Meconium staining, yeah. But again, babies are probably going to breathe through their nose. Meconium staining is a really good, or meconium fluid is a good, but not all babies have meconium fluid, and we're still suctioning every mouth first. So we don't stimulate breathing. That's not exactly it. Here's why. Baby has been living in an aqueous environment for its entire life, right? Baby has never used its lungs. So baby comes out, baby gets stimulated, baby takes his first breath. Is baby's first breath a nice, calm, no. Baby's first breath is an agonal respiration. It's a gasp. So go ahead and gasp right now. And you tell me where the air gets sucked into. It's 100% the mouth. All right. When baby takes their first agonal respiration, they're going to suck things down their mouth into their airway. And if there is meconium in the airway, that's going to be a problem. Now, there's not frequently meconium staining. I've delivered 5 babies. I've seen 0 meconium staining. But I've known people that deliver babies for a living, and they say it's more frequent than you'd expect. So it's absolutely a consideration. But no, we suction the mouth first because first couple respirations are going to be through the mouth. Now, when we're talking about infants and neonates for the first 28 days of their life, if you get there and they've got their noses all clogged up with mucus, that's a major concern, right? Because they're primarily breathing through their nose. But baby's first breath, way through the mouth. So that might help you guys remember that. All right. Don't do anything to the cord, wipe the baby off. So if baby's delivered normally, we don't do anything to the cord, we wipe the baby off. This will stimulate it to breathe. It's going to be covered with that white stuff. This is called vernix caseosa, which keeps the baby from becoming waterlogged inside the womb. It's like waterproofing. If all goes well, the baby will squirm around. Its movement will be jerky and uncoordinated. Initially, the baby will be gray, but it'll start to pink up over time. When a baby is first born, its respiratory rate is going to be like 40 to 50. After a couple minutes, once it pinks up, it's going to drop down to about 30, 35, where it's going to stay for most of its adolescence or most of its infancy. Obviously, if we're at high elevation, it's going to take a little bit longer for that baby to pink up. Excuse me. We know at the time of birth, and then we perform what's called an Apgar assessment. APGAR. They're in a weird one here, but they are appearance, which is the color, pulse, grimace, which we look at as their respiratory effort, or I'm sorry, their muscle tone, and grimace. A is their Apgar. Can't remember what the second A is. Aspiration, or it's their ability to breathe. And then, or sorry, R is respirations. I can't remember what the second A is. Appearance, pulse, grimace, activity. Sorry, activity is the one. That's this reflex irritability. So I'm sorry, that's the muscle tone. Oh my goodness. As you guys can tell, I'm not great at Apgar. Apgar's lowest score is a 0, highest score is a 10. We assess this twice, once at 1 minute and once at 5 minutes after delivery. Clamp the cord about 10 centimeters away from baby. Put the next one about 2 inches away from that and cut between the clamps once the cord stops pulsing. Watch the end of the cord for bleeding, and if it continues, apply another clamp. Wrap the baby up, cover in head to prevent heat loss. So newborn babies are not very good at maintaining their heat or thermal regulating in general. In fact, they're not going to be able to sweat. Newborn babies can only sweat on their forehead. Preemies can't sweat at all. All right. A lot of times we're going to place baby on mother's abdomen to try to allow her to nurse. We want baby to start nursing from mom's mammary glands. This is going to cause an oxytocin release, which is going to cause the uterine to contract, which will help expel everything that's still inside. Is this fun for the mom? And no, it's not. Okay. Baby's probably going to bite and gnash, and may not suckle at all, and cramps hurt. Do not pull on the cord. It's going to come out. Now, that being said, I've seen lots of OB nurses pull on the cord. The mother's going to lose about half a liter of blood. This is normal. And finally, the placenta will come on out. One of the craziest things I ever saw as a paramedic was after I did my OB delivery rotations, I went into the nurse took me into a back room. Doesn't matter what we were doing in that back room, but in that back room, there was buckets, multiple buckets full of placentas. That was something I did not think I was going to see. And everyone was all normal about it. So that was an interesting thing to see. Check the perineum for any tears. And then you can also perform what's called a fundal massage on the top of the uterus, on the top of her abdomen, to assist with controlling of the bleeding. I've never done that before, but I've seen other nurses do it. So IV access, ECG, cardiogram, fluids IV as needed. Might need pain medication, might need oxytocin to assist with contractions. Be careful with oxytocin though. Antepartum and postpartum contractions. So this graph is showing the new age of, in 2013, the age of mothers when they gave birth. What we're seeing as a generalized trend is mothers waiting longer to have babies. It used to be that you got married and had babies in your 20s. Now that's becoming less common due to a whole number of societal changes. But we're also seeing a couple of complications associated with that. The most important one that we might deal with is preeclampsia. And then if left untreated, that can lead to eclampsia, which is seizures induced by pregnancy. This causes hypertension, headache, low urine output, and protein in the urine called proteinuria. Happens in 5 to 8% of all pregnancies. We does not take a high blood pressure, as high as you would suspect, in order to cause preeclampsia. If you see a mom with a BP of 140 or 150, you need to be highly concerned. If it gets much higher, she could very easily start having seizures. Seizures might not be so damaging to mom, but they might be very damaging to the baby. It's more common in women who are under 20 and over 35. That's kind of the sweet spot for giving birth, 20 to 35. Hypertension is a key feature, usually 140 over 90 or higher. Gestational diabetes, also caused by pregnancy, about 4% of pregnancies. Mother's inability to metabolize carbohydrates causes a transfer of glucose and fats to the fetus for storage, leading to a condition called macrosomia, where the baby grows bigger than usual. Baby's getting all sugary and big. The problem with this is that they're going to have very large birth weights, increases the risk of injury, and usually means that we're going to have to perform a C-section. It also puts the baby at a higher risk for developing type 2 diabetes and being obese and having respiratory problems later in their life. Mom is very likely to develop this the next time she gets pregnant as well. Next is problems with the placenta. Placenta previa is when the placenta implants too close to the cervix opening. And then when the cervix starts dilating, the placenta is going to start bleeding through that opening. This is also a problem. It happens about 1 out of 300 pregnancies. You can discover this on ultrasound because we can look and see exactly where the placenta is implanted. Now, if this is the case, what they're very likely to do is just keep mom from inducing labor, and before her expected due date, they're going to perform a C-section so that we don't ever have to worry about this. When the cervix begins to dilate, the placenta begins to prematurely separate. Now, the big risk with this is that this can stimulate the baby, and the baby's going to start to try to breathe when it's in an aqueous environment. It doesn't need to implant directly over the placenta, or directly over the cervix. It can implant close so that its blood flow is interfering with the cervix, and that's going to cause bleeding as well. Placenta Accreta, Placenta Accreta. This is when all or part of the placenta attaches abnormally to the uterus. So it does not attach into the uterine wall, and then it's very likely to detach, rupture, and cause internal bleeding. Probably not going to be a viable pregnancy at that point. We have different names depending on where it implants. Don't worry about memorizing those. Usually occurs due to scarring in the uterus from C-section. If we have to perform a C-section, we have to cut into the uterus. This is going to cause scarring, and then it's less likely to implant in that area again, or if it does implant there, it's going to have troubles getting through that scar formation. Uterine rupture, literally what it sounds like, the uterine rupturing, the globe breaking. This is a very catastrophic event, very likely to cause fetal death, also highly likely to cause maternal death due to the amount of blood flow we're talking about. Rare though, 1 in 1,400 pregnancies. Usually caused by trauma, but maybe at the site of previous C-section if it's recent and if it breaks open, if it wasn't closed up properly. It's going to be a sudden tearing. They're probably going to go into active labor. So you're going to see this pretty frequently. Whenever mom is pregnant and then something very traumatic or huge happens to her, she can sometimes go into labor as a way to try to prevent that or try to defend against it. Placenta Abruptio. This is when the placenta comes off of or starts tearing off of the uterine wall on its own. Not very likely to cause fetal death, but it can. High blood pressure, trauma, previous abruption, use of medication to induce labor, like oxytocin, or multiparity, having multiple babies. Due to them moving around, we can potentially tear off part of the uterine lining. Depending on how much gets torn off will affect how much the circulation is affected. Next, abortion and miscarriages. So abortion is what we call when it's before the 20th week of gestation. Lots of classifications. It doesn't matter whether it's accidental, like a miscarriage, or whether it's performed in a hospital as a way to terminate the pregnancy due to a variety of reasonings. It doesn't matter as far as our considerations. All right, hyperemesis gravidium, caused by the chorionic gonadotropin. If we have excessive intractable nausea and vomiting during pregnancy, this will lead to dehydration and electrolyte imbalances. Again, that chorionic gonadotropin, man, that stuff sucks. Can lead to GI injury, esophageal tears, dehydration, even maternal death in extreme cases. We might need to terminate the pregnancy if it cannot be resolved through other means. Pulmonary embolism, amniotic embolism. We know what a pulmonary embolism is. What's an amniotic embolism? It's the same thing, but in the fetus. It's the leading cause of death in pregnancy, pulmonary embolism, due to the effects of the gravid uterus on the circulation of the lower extremities, causing DVT, which migrates to the lungs. You guys know that DVT happens when we usually sit in one position. Like, think about international flights are notorious for this. If you sit in one position for a long time with your knees bent and you have already compromised circulation, then when you get up, clots may have formed, and then it's going to have no problem getting through your nice big veins and nice big vena cava, and have no problem going through the heart. It's going to come into problems when it goes in the pulmonary circuit and enters those tiny capillary beds, and then it gets lodged. That's when we're going to get a pulmonary embolism. This can very quickly kill baby. Like it says, the leading cause of death in pregnancy. Premature rupture of membranes. Hydramnios, we don't need to go over those. All right. Next one is cephalopelvic disproportion or shoulder dystocia. This is when baby's head is too big for mom's pelvis or baby's shoulders are too wide for mom's pelvis. How do we deal with this? Well, either through a C-section, if we can tell by ultrasound, or we might have to, in extreme cases, dislocate baby's shoulder in order to get him out. We can't dislocate baby's head, right? If this is the case, we're going to need an emergency C-section. But if this is the case, we can literally just break or dislocate the clavicle to get baby's shoulder out, which sucks, but what are you going to do, right? We need to get baby out or he'll die and mom might die. So we might need to break baby's shoulder to get it out. Now, are you and I going to be breaking baby's shoulder to get him out? No, not realistically. But it does happen. cord prolapse and cord presentation. This is important because this one presents a little differently. So if you are inspecting, looking for the head of the baby, and you see a cord coming out, that's a problem. You need to push that cord up and in. And this also is one of the only times you're going to be placing your gloved hand inside of mother, all right? Because we need to keep the cord in there. The problem with the prolapsed cord is it's getting kinked off and it's going to cause ischemia to the baby. And if the baby gets bothered and starts not being able to breathe, it's going to start moving and kicking, and it might start breathing, trying to breathe on its own, thinking it's been born. So we don't want any of that. So we need to push the cord back in there so that we can maximize the circulation, keep mom from pushing, have her put her knees up to her chest, and then take her into the hospital like that. There's not a whole lot we can do. The uterine can even prolapse if mom has a very explosive delivery. Oh, I always love these photos. How do you get it back up in there? Well, it's not exactly a soft and gentle process. You literally just push it back up in. Post-term pregnancy and prematurity. So we know that it's expected to be 40 weeks, but it starts to become a problem if the baby doesn't want to come out on time. Now, the earliest a baby has ever been delivered and survived is 21 weeks. That's amazing. 21 weeks. Our lungs aren't even fully formed until 27 weeks. That baby was extremely small. But while that was the earliest delivery ever made, it's not the smallest baby ever delivered. The smallest baby ever delivered was 8 ounces. And that was here in San Diego. And that was not that long ago. I think it was in 2016 or 2017 that happened. That is the smallest baby that's ever been delivered and survived. All right, multiple deliveries, twins, triplets, rare, 1 in 80 every 90 deliveries, triplets and 1 every 8,000. They're very rare. Increased complications, right? Very likely that with multiple births like this, we're going to need to have C-sections, because the likelihood that the placenta is going to implant in the wrong place, or we're going to have cords tangled up, is going to be a problem. Now, this is showing fraternal twins where there's 2 separate placentas and 2 amniotic sacs versus identical twins where there's 2 forming on the same one. It's the same baby forming twice, as opposed to fraternal twins, which are 2 siblings being born at the same time. There's a bunch of pictures of weird baby formations there. All right, we're going to finish up this birth section and we'll take our lunch break, guys. Breech births, anything other than the head coming out. We have a couple different names, frank, footling, and complete. It all depends. The problem is baby's not coming out the right way. Now, why is this a problem? Because when baby starts to get stimulated, because everything's come out except for the head might get stuck, because the head and the shoulders are the biggest part of the baby. So that's the most likely thing to have trouble expelling itself from the womb. So if we can't take care of that, we're very likely to get baby stuck, and then he'll become bothered, and he'll start trying to breathe while his head's still inside the womb. That's not good. And then precipitous delivery is when it's rapid, spontaneous delivery less than 3 hours from onset of labor, usually caused by overaggressive induction of labor medications, Pitocin or oxytocin. Also can happen when mom's had at least 6 babies before, grand multiparity. Trauma in the pregnant patient. Spoiler alert, it's not good. With minor traumas, 1 to 3% of fetuses can die. However, life-threatening injury to mom, fetal death is also very much compromised. Motor vehicle accidents account for the majority of these. But also, unfortunately, a significant amount are violence towards pregnant women, being abused. Penetrating traumas, obviously very devastating to baby. If we rupture that uterus, we're talking about huge blood loss, dangerous to mom, dangerous to baby. Penetrating trauma to the abdomen accounts for fetal fatality rate of 2 out of every 3. Depends on quite a few things. It depends on mom's health, the severity of the trauma. What's likely to happen is that traumatic injuries can cause spontaneous abortion, meaning that mom's going to go into labor and the baby's not fully formed. Before 20 weeks, I don't think it's really possible for a baby to survive outside of the uterus. 21 weeks was really pushing it. Here in San Diego, we don't even consider it a viable pregnancy if it's under 20 weeks. All right. So if a woman is pregnant, she goes into cardiac arrest. Fetal survival is extremely rare, but it has happened. But again, it's unlikely. So how do we want to treat pregnant women with trauma? The only thing we can really do to help baby is oxygenation. Baby's going to be a lot more sensitive to that drop in O2 than mom is.